Hello, everyone, and welcome to another episode of Autism Stories. I'm your host, Doug Bletcher, the founder of Autism Personal Coach. Autistic people are the true experts of the autistic experience, and Autism Stories is where we interview autistic people to learn from their diverse stories, experiences, and get their insights. If you'd like to be notified about each week's episode of Autism Stories, we suggest you subscribe on your favorite podcast listening platform. On today's episode, Bruce Petherick and Paula Holmes-Rodman join us to discuss the resource they created regarding supporting neurodivergent cancer patients. We hope you enjoy today's conversation. Bruce and Paula, thanks so much for joining me here on Autism Stories.
Thank you. It's nice
Good
to
morning.
meet you.
I'd love to start out, Bruce, by learning, where does your story in the autistic community begin?
When I was born, I am actually seriously, I'm somewhat late diagnosed. I was diagnosed about 8 or 9 years ago now, I suppose. So in my 50s. And the discovery of being autistic is a way of reframing everything that's happened before. And my response to being diagnosed was to dive deep into the autistic story. I read so many books, talked to people. It became a special interest, which is, not an unusual thing for an autistic person to develop, especially being late diagnosed. And that turned me into applying for a job at Autism Canada, and I was the autistic advocate for 4 years. And now I've gone back to music, which is kind of what I did for 50 years previously, but I'm also an autistic coach. I won't say life coach because I tend to work with older autistics and also high school age children. That's the nutshell.
The two of you recently did some work on supporting neurodivergent cancer patients and have created an important document around this. One of the important items I think for people to know about is that neurodivergent cancer patients are at higher risk of late cancer diagnosis and having poor outcomes maybe as a result. So what do we know about much later cancer diagnosis and why it tends to occur within the neurodivergent community?
Well, it sort of starts, so I work in cancer care as well. And it starts with the diagnosis and screening. So the screening process for the cancers for which there are screenings are inaccessible. There's all sorts of sensory barriers, there's communication barriers. So even if things like mammograms, things like prostate exams, things like all of those things that we're supposed to be doing, they're difficult for neurodivergent folks to actually access for all the reasons we can imagine. So if people get diagnosed later, then they're more likely to have poor outcomes. My sister Lindsay, she had ovarian cancer. She was diagnosed at stage 4, and most ovarian cancers are diagnosed later. But for her to be able to articulate her symptoms, to have her symptoms believed, and not to have diagnostic overshadowing, in which her symptoms were just described as autistic expressions of, herself rather than actually cancer symptoms. Had to get really, really bad. She had to end up in emergency multiple times. So, and then by then, of course, the cancer progressed, and fewer treatment options. And so at every time there's barriers and harms in the sensory information processing. And the longer you wait, the worse. But there's not a lot of research in Canada on autism. So we do know out of the later diagnoses.
It also, I mean, I have to also reinforce this is a reflection of systemic problems autistic people have. There is medical trauma. There is that, as Paula mentioned, social aspects sensory aspects that make it difficult for autistic people to be involved in the medical system. But of course, all our autistic issues with bad outcomes tend to be based in systemic problems, mm, because we struggle with interaction with systematic systems in and of itself. I hope that made sense. It did make sense as I was trying to articulate that.
It definitely made sense. And in your work, it's mentioned that patients may express pain and symptoms in diverse ways, especially those of us, I would imagine, that have communication and interoception differences, and alternate assessment tools are often needed. What types of alternative assessment tools may be helpful to us as neurodivergent people?
Paul and I discussed this. There isn't one test. There isn't one way. There is, again, a more generalized response to that question. Um, the medical community needs to be more aware of our differences so that when they are interpreting our responses, they can put it in the correct context. So, for instance, generally, autistic people do not do Likert scales very well. And the Likert scale is rate something 1 to 10. How does that compare to what's happened before? We don't often have, as we talked about, interoception, alexithymia. We have problems with recalling. Like, for instance, let's talk about pain. If someone asks me, "Are you in more pain yesterday than you are today?" I don't know. I really honestly don't know. I still may be in pain, but I can't tell if it's changed from 1 to 2. So we tend to then either answer the question we think the person who's asking the question wants us to say, or go to extremes. So it's either 1 or 10. Things in the middle don't exist. Mm. Paul, do you wanna jump in on this, or you want?
Yeah.
Like, I'm gonna rant.
Yeah, no, no, hey, rant away, Bruce. For my sister, Lindsay, she answered what I call aspirational. So, for example, I was with her. She had a brain metastasis, which is a rare expression of ovarian cancer. She was in a lot of pain. I could tell because I knew her body. I could see her cringing. I knew her very well. A nurse would walk in. This is post craniotomy, massive surgery, huge tumor removed. How's your pain? Rate it 1 to 10. She'd say, it's a 2, it's a 3. And I'm like, it's not. No, it's not. Because if you say 2 or 3, because that's that people pleasing response, someone who is assigned female at birth, particularly got that high masking, she wants to be a what I call a well and good patient. She wants to be a good patient. So that means she's answering what she feels like a good patient should answer. So the nurse is like, great, fantastic, you're doing well, walks out of the room. My sister gets no pain control rather than saying, actually, this is causing me a great deal of pain. So then there's an over reliance on a caregiver for me going, actually, she's cringing. She's doing these things. She actually does need pain control. So there's so the 1 to 10, Bruce says, I agree. I think my sister also had difficulty saying what's the difference between a 4 and a 6, a 7 and a 3. Mm, But there's that people pleasing, high masking, well and good patient answering aspirationally as well. So having a conversation with her, getting to know what the baseline, how a person expresses pain first, is ideally what needs to happen before you just sort of say 1 to 10, something to 2. Well, we're doing well. Walk out of the room. The person suffers.
We don't mean to criticize very specifically nurses here in this situation because they tend to be the
Yeah.
first point of contact. But there is a problem with medical systems throughout the world, and I'm going to expand this into like even a diagnosis, is the single glance. I have 10 seconds to work out what you need because that's the way the system is telling me I should be. The parallel is the enormous number of women that I have met, I have talked to, I have tried to counsel, who have tried to get a autism diagnosis, walk in, make eye contact, and basically they're going, "Oh, you can't be, you're not autistic." And it's like, I mean, one, this doesn't happen to male subjects very much, but it's also like this judgment in 5 seconds is crazy in the diagnostic level. But one might even argue when we're talking about, especially late stage cancer, pain, that 10-second response is not enough at all. Hey, you come out of surgery and say, "What's your pain level 2?" No, 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 that should not be true. That cannot be true. You can't have a pain level of 2, assuming one's low. You've just had massive surgery. Mm, Why that's not flagged, why that is not a red flag all of the time, confuses me, confounds me.
It sounds like, and I've supported a lot of people, autistic people in medical appointments. It seems like some of the things you're talking about right now have to do with sensory processing differences and medical professionals not giving us as autistic people and neurodivergent people as a whole time and space to process some of these things.
Agreed. Yes. And that's why actually we created the nursing guide, because all of Bruce and I started together creating a guide for patients and caregivers. And then we realized that was only part of it. Right. So we needed to help the nurses actually learn something. And so there was an opportunity for the Canadian Association of Nurses in Oncology, which is where this resource that we're speaking about today is housed, that they need to actually say there is a population, and I use that word, loosely and with all kinds of air quotes, that is doing worse in our cancer care system. And here in Canada, we have specific navigation programs for what they call underrepresented and marginalized populations that they know do worse in our cancer care system. Indigenous people, rural and remote folks have more difficulty and accessing cancer care. Adults and adolescents and young adults. So we have navigation programs for these populations that are crafted around why these populations do worse in our cancer care system. So we also need that for neurodivergent.
And all this is, of course, as well, is that we are arguing for better navigation system for neurodivergent patients, recognizing that as Paula said, underrepresented communities, populations, people have ticked on that, already ticked in their boxes, that needs to be looked at. And of course, what all of this is doing is also helping everybody. If we open up the navigation system to help neurodivergent people, we're also helping the neuromajority, recognizing that. For instance, you talked about processing of sensory information. Doctors' offices, bleak, bland, highly lit. Everybody walks in. It's a stressful situation. Everybody's processing is going to be diminished. It's going to take a lot more time. And the system is not built for a doctor telling you you've got stage 4 cancer and you have to react immediately. Like, we shouldn't expect anybody to react immediately. And too often there are cases where you have to make a decision without any ideology of any idea of the processing time. But the environment is making that really difficult for us, and it making it difficult for everybody. For instance, why we don't have support, like anybody going in for a bad cancer diagnosis from a doctor should have a support person with them, and it should be just like you need to have a support system.
Now, you provide recommendations for oncology teams to help close the gap with neuroaffirming accessible care practices. One of your recommendations is to provide navigation support between disability, independent living, community living, palliative, and cancer care systems. That's a lot of systems and definitely makes me think about executive functioning, as well as anxiety about potentially navigating these systems, especially once someone has a cancer diagnosis. Executive functioning is hard enough to begin with. Now we're throwing, a cancer diagnosis in. Are there any examples from oncology teams to show how to effectively do this? And if not, what do you envision that could possibly look like?
Well, to sort of define the problem, all of those systems that we just here in Canada, anyways, they're silos. They're incommunicative silos. They each might function kind of okay. The disability system, the community living system, palliative care system, cancer care system, they all kind of function okay as silos. Now, also in Canada, we have our healthcare is delivered provincially and territorially, not federally. So that means the cancer care system that you experience in our province in British Columbia is going to be different than the one in Alberta, where my sister received care. So they're all different. Um, but yes, asking anybody to sort of navigate between those silos when literally the charts don't even match up, the medical charts, is an impossible task for anybody, even when you're feeling super well. Um, I think there is a program in Canada. There should be. The best one that we found is the Dana Farber Neuro Inclusive Oncology Program, and that would be it's a pilot program. I think it's been going on for a number of years because they see autistic and other neurodivergent folks as a marginalized and under that needs help navigating. So the other problem is that even the palliative and the hospice services are in fact inaccessible. Although my sister received the most autism affirming care in hospice, she did better as an autistic person in hospice than she did in active treatment with more autism. The story ends up being with the patient. It is their responsibility to carry all of their needs, all of their accommodations, all of the advocacy burden as they move their way through these systems. And that's an impossible.
I have some medical complexities. I had a pretty dangerous heart condition when I was younger, mm, and that had caused me some problems. So every time I go and see a new doctor, it takes me about an hour and a half to explain my history that they need to know. So for instance, I have a strange heart. If you listen to my heart, it stops once a minute, approximately. It's fine. It's kind of that's the way my body works. But if you don't know my story, you're going, your heart's having a problem. I needed a cardiac surgery. I need to get your ear, blah, 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 blah. So that information, I have to tell my doctor. I have to tell my wife. And I often will tell friends, like here's my 30 pages of medical history you need to know just in case something happens to me. Adding autism to that, I haven't added that to my file yet. Fortunately, nothing's happened in the last like 10 years. But the fact that it's my responsibility to share this information to people within this system we need to trust. And as human beings in our society, we need to trust the medical system. And yet mistakes are going to happen all the time because this information is not transferred within. And I'm talking about really the medical aspect of this, the fact that this doesn't get transferred to palliative care, et cetera, et cetera, et cetera, is systematically crazy. Systematically crazy.
So I'm wondering about all your recommendations. Are there any particular ones that jump out to you as things that immediately could help, you know, cancer diagnoses, occur much quicker and provide better outcomes for neurodivergent people?
I think the biggest takeaway, we had a task when we were given the structure for this resource for the nurses that we were given, and they gave us, a page and a half, and and we had so many ideas, and we had to squish it in, and we weren't allowed footnotes, so that was difficult. So every word is crafted in there, but I think the most important phrase I think is to think about to invite, in fact, insist that oncology nurses think about how they communicate before what they communicate. Because it's no matter how much incredible knowledge that oncology nurse has, unless and until they know how that person, the patient communicates, they're useless. They're completely useless. So they can't just sort of walk in, impart knowledge, give a link to a website, give a paper pamphlet, ask your 1 to 10 Likert scale, and walk out and think they've done their job. They may be compassionate, kind, knowledgeable, all those fantastic things. But so it's that sort of think about how you communicate before think about what you communicate. So I think that's the sort of number one takeaway. And then the other piece is that I always speak about is how things like situational mutism, meltdowns, and shutdowns that happen frequently in healthcare encounters are misinterpreted as non-compliant or as refusal of treatment. So it's sort of inviting, just putting that little tick in the back of the oncology team's mind saying, is it really? What's going on?
Recognize what the differences are. And again, as Paula said, situational mutism, sensory issues, yeah. Uh, these need to be questions. These need to be questioned. These need to be um, thought about in any interaction. And then the idea of so much of our communication is one way and one type. So it's like, here is some written information. People don't process bits of information that are necessary to be communicated to get to the person who needs to know that information. My wife doesn't process written words very well, but she's really, really, really good at spoken and experiential, like extremely, extremely much better than I am. I like reading. Reading is good for me, but it's like we have to have all that information in those modalities, and we have to understand who you're giving that information, how they're going to respond, what the possibility of their responses are going to be, and not prejudge.
And then finally keeping the what I call the checking understanding. So we have these white patient boards. And from when my sister was in the hospital, I always wrote because her autism is not on her medical chart. So I would write in green marker, Lindsay is autistic, simply because that wasn't on the medical chart. Slow down, which means don't come in there and go really fast. She literally could not take in that information. Check understanding and support sensory needs. So that checking understanding means that because again, that sort of Lindsay had a sort of a kind of form of situational mutism in which she would say, yep, yep, yep. So that looks like I'm understanding. It actually even looks like I'm giving consent. But for her, she was just completely overwhelmed and she was neither taking in nor getting out any medical information at that time. So it's not, someone doesn't need to be like in a full meltdown or a shutdown. It's just like we need to be checking understanding with all patients. Like, what do you need? Do you need to circle back? Can I come back in 10 minutes, in 10 days, at a phone call, in a meeting? And all of this takes time and sucks resources, but we need to be doing it.
As we've been having this conversation, and Bruce touched on it, you know, briefly, the thing that's been popping into my mind is about support people, because for a long time I have supported many neurodivergent people in medical appointments. And I'm wondering, what do we know at this point in terms of outcomes for neurodivergent people when they have a support person at their appointment or have support networks that can help them to navigate this challenging life experience?
There are no studies in Canada. And also, I can't imagine getting a support in which you say, okay, half of you get no support people and half of you get a support person.
Yeah.
You all get diagnosed with stage 4, cancer, off you go. But I think that, as Bruce said, like all of us, like we all need somebody to sort of check our understanding, to have those conversations with, to make decisions with. I want to flag something here though, because for female autistic people, those assigned female at birth, there is higher risk of being in inappropriate relationships or with coercion and control, as my sister was as well. So even those who have a partner, a support person, that can, they're more likely to be in unhealthy relationships. So it's do they have a healthy, stable relationship, a healthy, stable caregiver, a family member, of somebody who can help support them? And is that person actually going to be, wanting the best for them? Because I mean, as oncology nurses, they should be checking that all the time. But I think that's something that needs to be flagged a little bit more when we're looking at neurodivergent folks as well.
There are so many stories about similar those situations. As Paula's talking about it, I'm just going through yep, that person, that person, that person, where the caregiver, usually in the case of something of a partner, answered for the partner's what the partner wanted rather than what the patient wanted.
Yes,
Yeah.
I agree. And that's devastating. That's devastating. And that's devastating outcomes. And I think that, I mean, always oncology teams need to be aware of that. And that means, what does the patient want versus, and is the support person actually just there supporting that patient? Or is the support person speaking for, not speaking with? And I think that, I mean, always that should be checked in all cases, but there's a much higher risk if you've got the patient who suddenly loses their access to language, if they're language abled, or if the oncology teams perceives that the neurodivergent patient isn't available for that conversation because maybe they're not making eye contact, maybe they're stimming, maybe they're doing something because they're experiencing overwhelm in the healthcare situation. So the oncology team says, never mind you, I'm going to talk to your partner. And that can be devastating. I mean, it should never happen, but it does happen all the time.
Yeah, I mean, I've seen it firsthand where, as a support person, the medical person tried talking to me more so than the other neurodivergent person that I was supporting. And I just won't answer the question. I'll just say, hey, talk to this person. They're sitting right here. Like, I guess that
Yeah,
there is definitely, maybe I don't give myself credit enough as I should. There is a certain skill set to being a support person in those settings, isn't there?
Yeah. Yeah.
absolutely. Yeah. And it's that learning necessity. That's why we need to be, or that learning imperative for healthcare providers to say, who's speaking here? Whose voice are you hearing?
We in the community always use that assumed competence line, and this is an example of that, of if a neurodivergent person has lost verbal language, is non-speaking at that time, that does not mean they can't understand. And it also does not mean they can't communicate.
Yes.
Again, there's a multimodality of method of communication. Now, yes, like if there's a caregiver that you have a trust in, the professional has a trust in, yes, you can communicate some information, but asking the questions, asking, how do you feel? Do you understand? Always needs to go to the neurodivergent person. I've used this example. I used to give lots of workshops on to people, Santas, dealing with autistic children. And quite often the question would be like, is it okay if I talk to their parent, almost always a mother, and it's like, you've got to assume competency. Talk to the child, ask the child first, but also make sure the parent, the caregiver is involved. But the child first, the autistic person first.
And what that means is that I'm not sure of how it is in the States, but here in Canada, we have a very, squishy healthcare system. That's the technical term, which means everything's in a rush, right? So you get 15 minutes. So if you can't go in there and give your list and your bullet points, and you can't answer those snappy little questions, you're going to get left behind, right? So it takes a lot for any patient to go in and say, even if you're dealing with a, toenail infection, let alone if you're dealing with the stage 4 cancer, to say, and these are my questions, these are my concerns. What are the variables? What are the possibilities? It takes an incredible amount of executive functioning. So with my sister, I told her, I'll be your executive functioning. So I would go in with my lists and I would take quick little notes, and I said, you just be present. And then, so I would take notes, I would write it up, and then she and I would speak afterward and talk about what happened. That's kind of I mean, did I do it perfectly? Probably not. But that's the ideal situation in which you have the autistic person just able to be present, ask their questions, and you have someone else basically being the outsourced brain as well. And then having an opportunity to have that conversation later to talk about what decisions need to be made. If you have any questions, how do we follow up? How are we going to make this decision? How are we going to express consent? All of that stuff. But that takes a functional caregiver and a team, and that caregiver must know that person really well, right? So that again, that's the ideal situation. But then that's a lot of, rather than just saying, well, speak up and advocate for yourself, which is the default position of our healthcare system. Just speak up, ask for questions.
Paula's just reminded me of something. And Paula, this actually made me do a little story. So it's your story. I apologize. When you're going through an extreme medical situation, since we're talking about cancer, stage 4 cancer, there actually is a limited number of questions that a patient can ask of a doctor when you're getting into that situation. Let's say it's breast cancer. I mean, like, if you're going into a doctor's office, you're going to get a diagnosis of stage 4 breast cancer. There's probably 50 questions that almost every patient could ask. That sort of information should be ready to be given to the patient. That you've just been given this diagnosis. Here is a FAQ. Here is a book. Here is some resources that can answer some general questions. Read them, ingest them, talk them over, and then come and ask me again. That should be almost a default. And these 50 questions, this FAQ, maybe not get every single question, but it will get the vast majority, and also encourage the patient to be thinking about what medical responses should I be thinking about here? Like, what is the doctor going to want me to know? What type of things still am I going to go through? The vast majority of women going through pregnancy get the "What should I be expecting" book. And going through it in Australia, we had it, and then I found out my now wife had one, and people in the UK have almost exactly the same book. It's like, we're not expecting pregnant women to know what's going on. Here's a book tell you almost everything you need to know. This is the sort of information we need to have ready for us as patients when we walk in, to start the conversation, give us an idea of where we're going. I'm feeling very passionate this morning. I'm sorry.
Don't apologize for that, Bruce, for sure. Yeah. Kind of maybe following your line of passion about the FAQ, what do you think it would be important for our listeners to know about supporting neurodivergent cancer patients that we haven't necessarily discussed yet?
Well, I think that the resource that we created that we're speaking about today is for oncology nurses. It is just part of this. It's a drop in the bucket towards the solution. So it should be paired with the self-advocacy guide that Bruce and I worked on, which helps patients make a parallel medical chart, what we call parallel charting, about how that person sort of communicates, what their sensory issues are, what their routines, special interests are, what the support team is, all of those things. And then we also need to be fixating the inaccessible systems. So if you're walking into a healthcare system as a supporter of someone with cancer, and you're saying, you know what, that didn't work. That pamphlet you handed, that 5-minute appointment, uh, that may be all you get. But maybe that's worth a letter or a phone call or something. And as the person without the cancer, because we can't expect the person experiencing cancer to carry even more burden of now having to be super advocate in a broken healthcare system. So as a support person, you can say, you know what, that didn't work for my loved one, my friend. And you just make a note, and maybe you give a little feedback, right? Maybe you just say, you know what, we're doing this for other populations. Did you realize that you missed the mark here? And I think that's how we make these tiny little incremental changes forward. But also then to circle back to what we were saying before, ensure that if you have the privilege, the honor, and the work of caring and supporting someone with cancer who's also neurodivergent, make sure that you know how they express pain, how they interpret what's going on in their bodies, and how they are likely to speak about that, so that then you can be what I call a medical Cyrano, right? And you can use your powers for good. You can say, you know what, my friend, my loved one, actually is really suffering right now, or they really missed them. They didn't understand at all what you said. They need another appointment. They need a phone call. They need an in-person appointment, whatever it is they need, so that you can be that point of translation, that bridge between these inaccessible silos. So that is the best case scenario that you could do to support someone through cancer.
If I may emphasize something that Paul is bringing up, this is something we discussed before. A lot of systems built to deal with neurodivergent people, almost always their number one point is self-efficacy. And I think both Paul and I are coming to realize that there's too much emphasis on self-advocacy as a solution.
Agree.
And I love talking about self-advocacy to especially newly diagnosed people. I express how important it is. But I keep on thinking, even the fact of me wanting to teach people that self-advocacy is should, if as I take a step back, I'm recognizing there's not just them as a self, there's me as a mentor as well is happening in that discussion straight away, that's necessary. A lot of my work that I've done with Paula comes from my work in education. And I'm seeing parallels everywhere. And of course that expands to everything. And in education, we talk about the triangle. So you have the student, the teacher, and the parent, and they're all equal, and the input's important for all of them. In the healthcare system, what we thought about was like there's the patient, the caregiver, and the system. And again, those three things are so important for good outcomes. It can't just be the medical system being the important thing, or even the medical system and the patient. There needs to be a third stream. There needs to be some feedback. There needs to be some processing to help both sides. As Paula said, sometimes giving that feedback, like as a teacher, a student telling me, I don't understand what you're talking about. You've said this like 4 times. I don't understand. Oh, I need to fix something. I've been teaching for 40 years and this has always worked, but this student's having struggle, but they're telling me they've tried 4 times. Okay, I need to rethink. How am I articulating this? What's my example? Blah, 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 blah. Should also help on the healthcare system. If I may, I just remember that, Paul, I don't think I've ever shared this with you. For years and years and years, because I was probably a bratty little boy, people would ask me how I was, and I would say 4.7. And then, what does that mean? And I was clever, and this is very autistic. It's like I would change the scale for them. So if I would 4.7, sometimes that was out of 10, sometimes that was out of 4. But my response was always exactly the same. Now, you think, oh, that's a joke. But in fact, I kind of was just being as serious as I could. One, pointing out how silly it was that's sort of, how are you? How do you respond to that question? But your response being put in the proper context brings the truth.
And I think like something that you said earlier, Paula, we were talking about something a little bit different, but you were mentioning the silos of these different systems. And I think the conversation we're having, it's really about kind of like an interdependence versus kind of like independence of these things.
And I agree. And I think that asking people who have, I mean, most people who sort of walk into a cancer center have never been there before. And they're confusing and scary and overwhelming for everybody. And even if you've been there before supporting somebody else, it's very hard to walk in there as a patient yourself. And then when you're transferred from, say, cancer to palliative care, it's a cliff. It's a cliff dive. And you are then expected, you've just got this devastating news. Now you're expected to learn a whole new system and how to advocate for yourself again and how to access the system. And there's wait lists and there's wait times and there's, travel and there's transportation and there's how, like all of the things that folks can struggle with, let alone if you're already struggling to live independently. So, um, so that's and all of our cancer care system is predicated on the fact that you are fully employed, you have a healthy relationships, you've got some money in the bank, you've got all of this stuff. And then if you get cancer, well, it's still going to suck, but at least you've got that huge safety net. You've got friends, you've got family, you've got appropriate partners, you have ability to language, access to language all the time. You speak the same language as your healthcare providers. You live close to a big cancer center. Things might go okay, but not many folks have all of those check boxes. And then guess what? As I say, cancer comes to town, right? And so, but our system is predicated on all of those things. So it's quote easy to self advocate when you have that sort of power and strength behind you. But if you walk in and it just isn't. It just doesn't work that way.
And lastly, how can our listeners read your work, your resource, and learn more about supporting neurodivergent cancer patients?
I think the kids say link in the bio or something. So isn't what the cool kids say?
The kids.
The kids. Oh, we're so old. We can link the resource to you, both the resource for the oncology nurses and the ones for patients, the self advocacy guide. So those are free. They're accessible resources. They're free in Canada and they're free in the States as well. They may have some differences based on our different healthcare systems. So people are welcome to use those. We would welcome feedback on those as well. And we're hoping to continue our work on this going forward as well. But Bruce, go ahead.
It's always that, how do you find about our work? It's like, even websites are all old news now. Like
Yeah.
everybody can feel free to message me on Instagram and Facebook.
Yeah, right. We can do healthcare provider training as well. Yeah, we've both done that before. So
Well, I'm grateful to you, Paula and Bruce, for this conversation. Really important conversation. Thanks so much for talking with me today.
Thank you for the invitation.
thank you so much, Doug.
Thanks so much to Bruce and Paula for the conversation. To learn more about their resource on supporting neurodivergent cancer patients, please check out the link in the podcast description for this episode. We always love hearing from you and would especially love to hear from you after listening to this episode on how well do medical providers support your needs when you're accounting for sensory communication and or executive functioning differences. Did you know Autism Personal Coach provides support by autistics for autistics? We empower autistic adults and teens to be the best version of their authentic selves through customized life coaching. We also support parents and partners of autistic people by providing insights and guidance to bridge communication gaps and nurture mutual understanding. So please visit autismpersonalcoach.com to begin your experience of judgment-free coaching rooted in empathy, expertise, and respect for autistic identity. Until next time, I'm Doug Bletcher of Autism Personal Coach. Talk to you then.